Hi guys, my name is Haley and I'm going to be starting off this lecture on the infectious diseases of the skin and eyes. The first infection that we're going to be talking about is called cellulitis. Cellulitis is a skin condition caused by a fast-spreading infection in the dermis and subcutaneous tissues below it, and it's most commonly caused by bacteria. These are Staphylococcus aureus, more specifically the methicillin-resistant strain, as well as Streptococcus pyogenes. But in immunocompromised people, this can happen with almost any type of bacterium and even some fungi. So the way that the bacteria is transmitted is through parenteral implantation. So this includes trauma to our skin. So if you have some sort of cut, wound, or opening in your skin, the bacteria can get in there and enter our bodies. And it can also happen in more subtle means. It's generally not contagious, and it's most common in our lower legs because they get into the bacteria can get into cracks between our toes. Some of the virulence mechanisms for Staphylococcus aureus, there's exfoliative toxin A and coagulase. So the way exfoliative toxin works is it causes blistering on the superficial skin surface layers, but it's actually a toxin that forms the basis for another skin infection called staphylococcal scaled skin syndrome, which is related to cellulitis because it's one of the most common symptoms, but we will not be getting into that disease in this lecture. But this toxin binds to a molecule called desmoglobin in our desmosomes of our epithelial cells, and it breaks it up in a manner in which our cells or skin cells can lose adherence and more bacteria can enter. And then the way that coagulase works is that it is a protein enzyme that enables the conversion of fibrinogen to fibrin in our blood. And this results in the clotting of our blood. And that means that different leukocytes and macrophages will not be able to get to the infected area as easily. And then for Streptococcus pyogenes, there's streptokinase and its plasminogen binding ability. And so streptokinase interacts with the plasminogen in our bodies. Plasminogen is a major enzyme in our bodies that breaks down blood clotting. So when streptokinase binds to plasminogen, there isn't any breakdown of the blood clots. And it ultimately, those same immune cells can't get to the infected area as easily. Some of the symptoms of cellulitis are pain, tenderness, swelling, and warmth, pretty much the classic signs of inflammation, as well as fever and swelling of the lymph nodes. And this includes lymphangitis, which is pictured here in the screen. There is no vaccine to prevent it. A lot of these bacteria are naturally on our skin, so it's kind of hard to prevent something like that. But with the treatment and prognosis, most cases that are mild resolve well with oral antibiotics. But if you're immunocompromised, sometimes you'll need intravenous antibiotics. And if there's extensive tissue damage, sometimes it needs to be surgically removed. With the methicillin-resistant Staphylococcus aureus, vancomycin is used. And for Streptococcus pyogenes, penicillin is used. But with some other bacteria and fungi, there's a lot of the times just aggressive treatment with oral and IV antibiotics. So who does it impact most? There's highest incidences among males that are aged 45 to 64, as well as immunocompromised people. And they have to worry about it spreading to their bloodstream, rapid spreading to adjacent tissues, as well as children can get meningitis. Some other virulence factors present are pyrogenic exotoxins, so kind of like what I talked on the last slide, but there's also B, C, and F present. And there's also streptococcal superantigen that can lead to a more pronounced and invasive disease. So I wanted to lastly just talk a little bit more about Streptococcus pyogenes because we actually use this in lab. And so we know it's a gram-positive bacteria and it experiences beta hemolysis, which is shown on the blood agar plate that I got to create in lab. And then something super cool that I found out about it is it has hyaluronic acid in its capsule, which allows it to be undetected by our immune system. So yeah, that is the last bit of cellulitis, and I'll pass it out to the next person.
Chickenpox is an extremely contagious skin disease caused by the varicella zoster virus, also known as human herpes virus HHV3, which is an enveloped virus. If someone is exposed to the virus and not immune, they will almost always get infected. It's transmitted indirectly via respiratory droplets or directly through the fluid of active skin lesions. As for the virulence mechanism, the virus first attaches to the respiratory mucosa. It then enters the bloodstream, where it travels to the skin and cells begin to fuse and lyse, causing the skin lesions. It then enters the nerves where it travels to the ganglia and remains latent until it reemerges months or even years later as shingles. The virus's latency allows it to go unchecked by the immune system, thus providing a safe reservoir for it. After 10 to 20 days of coming into contact with the virus, the symptoms will begin to appear, and they will include a fever, which is followed by an abundant rash on the scalp, face, and trunk, which radiates out to the extremities. The rash is made up of itchy macules and pustules, which can be seen in the photo of the little girl on the right side of the slide. The lesions eventually leak clear fluid before crusting over and falling off. Patients are considered contagious until all lesions have crusted over, and symptoms are generally cleared up within 7 days. As for vaccine prevention, the varicella vaccine has greatly reduced the occurrence of the disease. It is most common in children, and it's recommended that children receive the vaccine at around 12 months of age, and then they get a second dose at age 4. It's usually considered a mild disease in children, but if an immunocompromised person or an adult is infected with the virus, complications can occur and the results can be life-threatening. Thus, it is better to contract the virus at a young age rather than later in life. Knowing this, some parents have brought their children to chickenpox parties, where if one child gets it, all of the other kids will come into contact with them for the purpose of being infected and gaining immunity. However, since the vaccine came out in 1995, chickenpox parties have become a lot less rare. It's safer to be vaccinated than for a child to intentionally be infected with the virus, and researchers have found that those who have been vaccinated have a decreased risk of experiencing shingles later in life. Most cases of chickenpox fully resolve on their own within 2 to 3 weeks of onset, but others caused by group A streptococci or staphylococci require antibiotics. Some immunocompromised patients may experience pneumonia as a result of chickenpox, and in more serious cases, a secondary infection of the heart, liver, and kidneys can occur. This will result in a 20% mortality rate for this population. For immunocompromised patients, oral acyclovir or other antivirals are administered within 24 hours of onset. In very rare cases, less than 0.1% result in encephalopathy or inflammation of the brain. After recovery, the virus enters the thoracic nerves of the torso and trigeminal nerve in the head. It can reemerge later in life as skin lesions or shingles. And if you would like another explanation of the chickenpox and varicella virus, the video I linked on the slide at the bottom down here is a really good summary of all the information, and it includes just some finer details of the virus in case you're interested.
Okay, so I'm going to be talking about smallpox. Smallpox is a skin disease caused by the variola virus of the gene orthopoxvirus. It is transmitted by primarily droplets. That would be a form of direct transmission, and it's also spread through contaminated bedding and clothing, and that would also contribute to the spreading. So if bedding in a hospital was contaminated and wasn't washed properly or replaced before the next patient, that would contribute to the spread of smallpox. The virulence mechanism. The virus gets implanted into the nasopharynx and then it invades the mucosa and multiplies in the lymph nodes. And then it leads to viremia, which is virus in the blood. And then the variola multiply in the white blood cells and travel to the small blood vessels in the dermis. And due to the presence of the virus, the lesions occur and scarring is left once healed. So there's some images in the top right that show these kind of lesions that form on the body. Then the symptoms, it begins with fever and malaise, which is just kind of a feeling out of it or just sick. And then later the rashes and the lesions begin in the pharynx, and then they spread to the face and then down to the rest of the body and the extremities from there. And as the lesions develop, they fill with an opaque liquid and they break open and this contributes to spreading the virus as well across the patient's body and to other people. A common complication with this is that the lesions on the skin can be secondarily infected with bacteria after they break open. And moving on to vaccinations. So the US stopped giving the live virus in 1972 to attempt to get rid of the virus, just to completely get rid of it. And the rest of the world was on board with doing this as well. And this push had or led to the virus getting eradicated. And the last natural case of smallpox was in Somalia in 1977. And then in 1980, the war on smallpox was considered won, and the World Health Organization advised all labs to destroy their stocks of the virus. There have been conspiracies that not every country has destroyed their stock, so this could lead to bioterrorism. And this was the idea was largely adopted after 9/11. So, yeah, it's still a possibility as a bioterrorism agent. And however, if this extreme case happened that it was used for bioterrorism, the US still possesses enough vaccines to vaccinate the entire population on demand. So the treatment for this, it is found that an antiviral drug called cidofovir is a recommended treatment. And the US government also holds a supply of this drug in case there's a public health emergency or bioterrorism incident that can be used to help reduce symptoms and just prevent the virus in general. And also antibiotics can be used if the complication happened and it was secondarily infected with bacteria. The antibiotics can help fight that bacteria and treat some of the symptoms.
Okay, so the next disease that we're going to look at is hand, foot, and mouth disease. And it's a systemic disease, skin disease, that causes blister-like spots. And these spots usually begin showing up in the mouth and then move to hands and feet, and sometimes can also migrate to genitals, buttocks, knees, and elbows as well. So some of the symptoms that comes along with hand, foot, and mouth disease, it can cause fever, sore throat, and malaise. And it's most common in young children, typically under 5 years old. So it's caused by an enterovirus called the Coxsackie virus, and it's typically the A-type 16 strain specifically. It's transmitted by direct contact with bodily secretions, such as saliva, blister fluid, feces. So this makes it really common in places where young children aggregate, like school or daycares. Its virulence mechanism, the virus enters the nasopharyngeal mucosa, moves to the lungs, and then begins infecting epithelial cells of the nasopharynx and the lungs. And it can result in systemic delocalization, or it can remain local at the respiratory epithelial site. And then in the bottom right, that's a figure from the textbook showing the little blister-like spots on the tongue and the lips, and then kind of the surrounding mouth area. So the treatment, there's really no specific treatment and no vaccine for hand, foot, and mouth disease, but most patients recover in less than 2 weeks with no subsequent sequelae. It is more dramatic usually and more harmful in older adults that contract the disease, but typically it is only in young children. The diagnosis, doctors can typically diagnose the disease by just looking at patient symptoms and the appearance of the rash or sores, and also by the age of the patient. Usually if you have a young patient with presenting blister-like sores, then you know that it might be hand, foot, and mouth disease. The disease was first reported clinically in New Zealand and Canada in 1957, and it was named by Thomas Henry Fluett. And the groups, like I mentioned before, that it most highly impacts are children in childcare settings. It's also more common in rural areas and in warm seasons. So seasons like summer, where there's a lot of moisture and humidity in the air, it's more common because there's a lot more secretions being passed. And also those with poor hygiene are a greater risk factor, which again is why in children that don't necessarily wash their hands after touching their mouth or their nose, this can pass more easily. And there have been the most outbreaks in Asia, specifically Taiwan and a couple other countries. But yeah, and that's a picture of the Coxsackie virus on the right there.
So now on to talking about measles. Measles is a skin disease caused by the measles virus from the genus Morbillivirus, and this is a single-stranded, enveloped RNA virus. And to the transmission, this is one of the most contagious infectious diseases, and it is spread through mostly respiratory droplets, which is direct, and the spread is favored if there's a large group of people or crowding, if there's low levels of herd immunity with minimal people being vaccinated, and inadequate health care in less developed countries. And the US set a goal to eradicate it in 1966, and it took until 2000 to accomplish this goal. And now, due to unfounded vaccination fears, it is making a comeback in certain communities now into the mechanism in which it spreads. The virus implants in the respiratory mucosa and infects tracheal and bronchial cells. Then it travels into the lymphatic system where it multiplies and enters the bloodstream. And then viremia, or virus in the blood, carries the virus to the skin. Then the virus fuses cell membranes of host cells, leaving them unable to perform their regular function. This includes the immune response and the cells involved with that. And it would prevent them from performing their normal mechanisms to prevent infection. So secondary bacterial infections are very common with measles. The symptoms, initially you'll have some sore throat, a dry cough, headache, and fever. And then it'll lead to oral lesions called Koplik spots as a prelude to a large rash that will spread throughout the rest of the body, starting from the head. The major complication with the measles virus is subacute sclerosing panencephalitis, or abbreviated SSPE. This is a progressive neurological degeneration of the cerebral cortex, white matter, and the brainstem. And this can occur right when or right after your measles infection happens, or it can happen years after. It's really dependent on the case. And it involves a defective virus that stays in your system after the virus is killed off, and it spreads through your central nervous system, destroying neurons and breaking down myelin. So there's a large impact on your nervous system, and most of the time it leads to a coma or death. So to the vaccination, it's a series of 2 shots, which is the measles, mumps, and rubella vaccine, or MMR. And recently, there's been a 300% increase in cases due to patients not wanting to give their children these vaccinations because of the fear that the shots cause autism in children. These are unfounded, and there's no data supporting this. But regardless of that, they have caused an increase in cases in the past few years. The treatment, there isn't an exact treatment for measles, but you really just want to treat the symptoms. So reducing the fever, suppressing cough, and replacing fluid loss. The best treatment is really just prevention and getting the vaccine to protect yourself and others. And some physicians found that vitamin A supplements can be used to reduce symptoms and limit the complications. And so really just get the MMR vaccine if you can, and that will help to slow the spread of measles and prevent it from making a comeback in our communities.
Okay, so the next disease that we'll look at is rubella, which is also known as German measles. So there's 2 types of rubella. The first is postnatal rubella. So this is the infection of adolescents and adults, and it's typically less severe than the other kind, which is called congenital rubella. So postnatal rubella is a systemic viral infection and begins in the respiratory epithelium. So the incubation period from when someone becomes infected to starts showing symptoms is typically 2 to 3 weeks. And typically the symptoms are mild. It can be a sore throat, malaise, fever, lymphadenopathy, leads to pink macules and papules, and can cause like a rash on the face. that will move towards the trunk area and then towards the extremities. So this rash, you can see down in the picture down here, that's postnatal rubella, and his rash is beginning to move down towards his trunk and extremities. So on the other hand, congenital rubella is a prenatal infection of the fetus where the mother transmits the virus to the fetus. It occurs typically in the first trimester, and if it occurs in the first trimester, it induces miscarriage or defects such as deafness, cardiac abnormalities, rashes, physical or mental retardation. So they're really severe defects that can possibly cause miscarriage in the baby. Less severe infections usually are ones that occur later on in the second trimester and can induce anemia, hepatitis, pneumonia, carditis, bone infection. So still pretty significant. And there's about 100,000 infants a year that are born with congenital rubella. And then in the right lower hand corner, you can see a baby that has the congenital rubella virus. The virulence mechanism, the virus inhibits mitosis and induces apoptosis, causing damage to vascular endothelium. And it disrupts cell division and growth in the fetus. Basically, that's what it means by inhibiting mitosis. And because in the fetus, mitosis is such a critical thing to occur, it causes abnormal organ development and can lead to the severe defects in fetuses that we see. So the epidemiology, it's an endemic disease and it's prevalent worldwide. The transmission occurs through droplet contact from humans, and these droplets can be respiratory secretion, sometimes urine, and it spreads after the prodromal stage. It's caused by the rubella virus, which is a virus in the rubivirus family. It's a part of the toga virus family. And the most impacted groups are adolescents living in close proximity. So these could be college dormitories, military training camps, anywhere where there's a large amount of adolescents that are kind of grouped together and living close. So the diagnosis occurs by the ELISA technique or the latex agglutination card to detect the presence of IgM antibodies. This can also be measured by acute and convalescent measurement of IgG antibodies. And a lot of times they will do both of these mechanisms to confirm that it is rubella and not something else. So rather than just doing one or the other, they usually double test you. Prevention, you can get an MMR or MMRV vaccine, which contains attenuated viruses. And you get these typically during infancy, and then you get a booster around age 5, and that protects you lifelong from the rubella virus. It's a single-stranded, non-segmented RNA with a loose lipid envelope and 2 different viral proteins that make up the virus. So it's a relatively simple virus, but it can cause a lot of damage like we've just looked at.
Roseola is a viral infection that can affect the skin by means of a maculopapular rash, which you can see on the right here. And it is caused by HHV6, which is a strain of the human herpes virus. Transmission of roseola is through respiratory droplets that can enter through the nose or the mouth. And the virulence mechanisms are not completely understood at this time. However, something to note is that the virus can remain latent after symptoms have cleared, which could elicit reactivation. But this usually only happens in immunocompromised individuals who have been infected. There's no vaccine for roseola, and generally there's no treatment if you are diagnosed with the disease. However, immunocompromised patients may be treated with ganciclovir, which is a broad spectrum antiviral, but this isn't the best treatment because it can have some really serious side effects, such as bone marrow suppression or kidney damage. So the symptoms of roseola begin with a quick onset of a high fever that can last several days, and it usually leaves on the 4th day. And the rash usually appears on the 4th day when the fever leaves, when the disease is almost done. The rash can appear on the chest, trunk, face, and limbs. However, most cases do not develop a rash. So to diagnose roseola, it's not usually very extensive or a specific process. It's usually just based on the symptoms of the high fever and the potential of a maculopapular rash. But because the diagnosis isn't extremely specific and the symptoms aren't extremely specific, it's easy to be misdiagnosed as measles or rubella, especially in countries that don't have vaccines for these diseases. So roseola is especially common in babies and young children, especially between the ages of 5 months and 18 months. And most people are likely to have had it or been exposed to it by the age of 3 years old. Roseola does not usually produce epidemics, and infection can generally occur at any time of the year. Also of note, about 1/3 of cases, even in healthy immunocompetent children, experience febrile seizures during the course of the disease. Luckily though, this doesn't trigger any sort of seizure disorder, and the seizures end once the disease has ended. Also, sometimes reactivation can occur in immunocompromised individuals, and this can lead to severe complications such as encephalitis or hepatitis, and these could be fatal. So next we have warts, which are a skin infection. Also, that can occur all over the body, and it's caused by viruses, and almost all warts are caused by the human papillomavirus or HPV. And warts, which are also called papillomas, can develop in almost anyone. They're especially common in children though, because throughout a lifetime, adults can build up an immunity to HPV. They're transmitted in 3 different ways. One is direct contact or skin to skin with an infected individual. It can also be transmitted through indirect contact, such as using a community shower or towels or improperly cleaned pedicure equipment. And the third form of transmission is autoinoculation, which is transmission from one part of the body to another. So like if you get a wart in your hand, it could autoinoculate into your foot. So the virulence mechanisms of human papillomavirus occur because it is a non-enveloped double-stranded DNA virus. It has specificity for epithelial sites. It can invade through skin or mucous membranes, and it's often through broken skin. It's easy to infect. And the virus infects the basal layer of stratified squamous epithelial cells, which then stimulates cellular proliferation using the host cell machinery. The cellular proliferation creates the visual appearance and texture that is associated with warts. And then this allows for the inhibition of retinoblastoma protein, which when functioning correctly is supposed to inhibit tumors. So then when the retinoblastoma protein is inhibited, it allows for growths to occur. And the different types of warts can exist because of the different types of protein products from this process. So there's no vaccine for warts, and there aren't any highly beneficial treatments, but warts tend to go away on their own, but it just might take a long time. Doctors do approve home remedies for warts, and a common one is the use of salicylic acid. Also, in extreme cases, they may prescribe drugs or cryotherapy. However, because the virus can integrate into the host cell DNA, many treatments don't often work, or they may alleviate the symptoms without actually killing the virus. Warts are usually diagnosed visually, and it's pretty simple to do so, but if necessary, biopsy and histological examinations may be utilized. So the symptoms of warts are the visual of benign squamous epithelial growths, but there are three major types that you can visually tell the difference between. So the first one is common or seed warts, which are usually painless. They're just elevated rough growths usually on the fingers, and these are caused by HPV strains 2, 4, 27, and 29. Next, we have plantar warts, which are deep and painful, and they're usually on the feet. And these are caused by HPV-1. And then flat warts are smooth and skin colored, and they develop on the face, trunk, elbows, and knees. These are caused by HPV-3, 10, 28, or 49. So here's some images of the different types of warts. On the top left, we have just the common wart on a finger. And to the right of that, we have the flat warts. And then on the bottom left are the plantar warts. So one common misconception about warts is that frogs and toads can transmit them into humans. However, warts can only be transmitted between humans, and it's not possible to get warts from touching frogs or holding frogs.
Hi guys, I'm here to finish off the lecture with the infection called conjunctivitis. It's also called pink eye, in which you guys might know better as. But conjunctivitis is a common contagious infection of the conjunctiva of the eye, caused by a lot of different types of bacteria and viruses. And there's actually 3 different types of conjunctivitis. There's neonatal, bacterial, and viral. So for neonatal conjunctivitis, it's caused by chlamydia trachomatis, as well as Neisseria gonorrhoeae. And for bacterial, the most common are Streptococcus pneumoniae and Staphylococcus aureus, as well as Haemophilus influenzae and some different Moraxella species. And some less common ones are the bacteria that cause neonatal. And then for viral conjunctivitis, there is adenoviruses. So as you can see, it's mostly just different bacteria and some viruses that cause this infection. So for transmission, here, I'll move my little. For transmission, for neonatal conjunctivitis, it's caused by vertical transfer from the genital tract infection of a mother. So if she has those 2 different types of bacteria present when she's giving birth, and that bacteria gets into the eyes of the baby, it can result in pink eye. And for bacterial conjunctivitis, as well as viral conjunctivitis, it's caused by vehicle transmission. So the auto-inoculation from a genital infection or sexual activity, as well as more commonly, probably just poor contact lens hygiene and some contaminated cosmetics. So it can be transmitted directly or indirectly. And same goes for viral. Some of the common symptoms are inflammation. For bacterial conjunctivitis, there's a milky white discharge. And for viral, there's clear exudate. A lot of the times it causes a mild pain, but a lot of the times there's a like itchy, gritty sensation of the eyes, as well as redness and swelling, and sometimes sensitivity to light. There actually wasn't any virulence mechanisms present in the book. So through research, I found zinc metalloproteinase in Streptococcus pneumoniae, and this causes an enhanced bacterial internalization by the removal of mucins in the eyes. So mucins are proteins that are found in our eye's glycocalyx layer, and it's said to act as a barrier for our epithelial surface. So when we remove these mucins, it allows for better bacterial adherence, and they can invade the conjunctival epithelial cells. And it also cleaves metalloproteinase 9, which is a key player in our wound repair of our epithelial cells. So for treatment, newborns a lot of the times will receive antimicrobials in their eyes right after delivery for prevention of pink eye. Treatment prior to lab results with erythromycin or gentamicin is super common, and the common eye drops that are given are gatafloxacin or levofloxacin, and normally it'll be just for like 2 or 3 days that you have to put these eye drops in. And a lot of the times viral conjunctivitis, it just needs to let its course run out, but a lot of the times antibiotics are still prescribed. There's no vaccine to prevent conjunctivitis. Some vaccines, such as those for rubella, measles, chickenpox, pneumococcal, and Haemophilus influenzae type B, help our body and other, help our body to fight off other types of infections, but these cannot stop conjunctivitis. For epidemiological features, neonatal conjunctivitis is caused in babies younger than 28 days old, and it affects less than 0.5% of the babies in the developed world. And bacterial conjunctivitis is more common in children, and viral is more common in adults. For the diagnosis, according to the CDC, generally doctors can determine what type of conjunctivitis you have just based on your history, different symptoms, and examination of the eye. But a lot of the times laboratory testing is not used, which can be a problem with what we talked about with antimicrobial resistance. And so if they are prescribing antibiotics for viral conjunctivitis, it could be teaching other bacteria in our eyes and around our eye surfaces to become resistant to certain antibiotics. Just to finish up a little real life story, I personally have never had pink eye, but I know my little siblings have gotten it before, and a lot of the times little kids can get it through fecal matter and some of the bacteria that's in fecal matter. And I also had a friend in high school who had conjunctivitis 2 different times our senior year of high school, and we kind of narrowed it down to there being contamination in her mascara. So honestly, it can be caused through a lot of different things or different hygiene practices. And it's super common, but really easily cured. And then here is our sources. And thanks so much for watching, guys.